Questions?
Hi, Catherine.
Hi.
I'm Anahita.
Hi.
Good to see you. So I was working at City of Hope Duarte for about a year. And then I had to deal with all these complications of the checkpoint inhibitors. So I don't think that the clinical gastroenterologists and communities get a chance to deal with these complications. They were like all fatal, basically. So it's not like a chemotherapy that, okay, you will have, some vomiting, some diarrhea, some rash, your hair is going to fall out. Now, when we are talking about autoimmune hepatitis, it's fatal. Autoimmune colitis is fatal. Autoimmune gastritis. I had a patient who actually had gastric cancer, 24-year-old. And then she presented with bleeding, and on endoscopy, when you look at it, it was like one huge ulcer, the entire stomach. Stomach eventually ruptured, and then the patient ended up with gastrectomy. The kind of like special kind of like IBD that we see with these checkpoint inhibitors are like unbelievable. It's basically these are new diseases, I would say, on the GI horizon, that we don't know how to treat. The only thing that we have for them is solumedrol, infliximab in massive doses, and fatality and immortality is really, really high. So and when you talk to oncologists, they send these patients to you a little bit too late. For example, this diarrhea, the patient had diarrhea for like 1 month, and they just kept giving the same checkpoint inhibitor. By the time the patient came to me, I mean, it's just like imagine a Crohn's, unbelievable Crohn's, which has involved the entire the GI tract. So they don't stop it. The only thing that they think of is like, let's stop. The patient is cancer-free. We don't care that the patient doesn't have a stomach anymore or doesn't have a liver anymore, but the patient is cancer-free. Seriously, this was their mentality. The patient with autoimmune hepatitis caused by the pembrolizumab for melanoma who was sent to me was had an AST/ALT of 300 for 3 weeks, and they didn't stop the medication. They sent the patient, and we are talking about City of Hope, the melanoma guru who was managing this patient. By the time he came to me, it was too late. We admitted the patient, LFTs went up to like 2,000, 3,000 patient decided to go on hospice. The patient died. So I think, I don't know, you guys have got to come up with some ideas, maybe make an atlas, start to more talking about the complications of these checkpoint inhibitors. These are not regular checkpoints that regular complications and side effects that we see with any other medication.
So
the question is really checkpoint inhibitor complications in cancer, in liver disease patients.
And I'll let Rich comment on this too, but in my, and I've done actually a lot of research on this, and I've given a couple of talks at AASLD on treatment of checkpoint inhibitor side effects. I think number one, yes, they're very well tolerated for the predominance of patients, but you have to warn the patient that there are complications, and it is possible that you can end up with an adverse event, and it's possible that we won't be able to stop it. So that's a conversation I always have in detail with the patient. You really just have to set expectations. But I think the important thing to remember with the immune-related adverse events is every single one of them, the earlier you treat them, the better the outcome is going to be. So as you said, if you wait too long and you don't treat them until it's very advanced, you're going to have much worse outcomes. You really have to jump on them quick. And then you can treat, and actually the patient can stay on therapy. It's not like if you get them on treatment fast enough and you get them under control, you can actually restart the immunotherapy and they don't necessarily relapse. Rich, what's your experience?
So these drugs have revolutionized the way we manage patients with cancer. The risk-benefit is clearly in favor of the use of these drugs when the data supports the efficacy. But with that being said, and your point, when I saw a patient to get chemotherapy, I can tell them you'll have cytopenias, you'll lose your hair. With the checkpoints, and like you said, Kat, we don't know what any patient's going to get or how bad it's going to be. And I think the new generation of oncologists are being trained to be familiar with this because these are the drugs that we're using. But I would also say this specifically in the liver cancer context, and and obviously it's self-serving, but as these drugs roll out into the broader community, for docs who see 2 or 3 liver cancer patients a year in their general oncology practice, they're not going to manage these patients as well as I think a place which has a high volume and a multidisciplinary center where I can call Gina and she'll see the patient right away, versus in the community where a lot of people do GI and not necessarily hepatology, and there is going to be a learning curve. And I called that out during my lecture. You need to pay very close attention, because once the bilirubin starts to go up, it's a little too late.
Yeah.
But your point is well taken, because if they do have liver failure from this medication from autoimmune hepatitis, they're not transplant candidates, right, because they have their cancer diagnosis. And I think the point Richard made earlier about what are you dealing with? Is this DILI? Is this autoimmune? Or is this drug-induced autoimmune? And so I think the sooner you get them into treatment and just make sure that you talk to them in the beginning, this is life-saving, but if you have this complication, it could be really bad.
And do a biopsy.
And then to do the biopsy to figure it out.
So do your oncologists put them on corticosteroids before they call you, Gina?
It depends on the toxicity. And I'll be honest, with liver function, it's very hard, because you're starting patients whose baseline AST/ALT is 110, 120, and even patients on sorafenib will fluctuate, right? And it's a matter of watching these patients closely. Some of these drugs are given monthly or once every 3 weeks, and I don't think I can just give it to them and say, come back in 3 weeks. I mean, I watch them closely, check labs maybe weekly at first. And the toxicity can happen even very late, right?
Yeah.
Most of it happens within the first 3 to 6 months, but you can see very delayed toxicity, and you just got to keep it in your mind, right? So when I see elevated enzymes turn new, the first thing I do is image them. If they're having progression, most likely that's the cause. But if they don't have progression, then I need to have them see hepatology.
And I think currently the guidelines or guidance are written by oncologists. So if you look at the oncology literature, they'll say, give solumedrol, give prednisone 60 Q3. As a hepatologist, I've never been that aggressive with prednisone. I mean, I give 40 a day, and I'm watching them very, very closely.
Jeff?
So I don't.
We give a lot more than that.
Yeah.
I'm sorry, what?
Jeff, we know UCLA's has a good tennis program, but they're not really the liver specialists at USC. So, what do you guys do at USC?
Snap.
Oh, is that?
Ouch.
So I see a lot of patients actually who have advanced liver disease and advanced cancers, and I got a call that their bilirubin's 15, their enzymes are up, and then the question is this just progression of their tumor and decompensation, or is this a complication of their treatment? And usually the patients have gotten a lot of steroids and things, and I think in those cases you don't want to harm somebody by over-treating something that isn't the problem. And in the cases I've seen that have actually had biopsies, I don't think I saw one biopsy where it really looked like it was the treatment. It looked like it was the progression. I think it's much easier when they come in, they're being treated for renal cancer or melanoma, and come in with, obvious drug-induced related immune reaction in their liver.
Vinay?
Sure. So I did see one clear case of nivolumab-induced hepatitis. I mean, it was based on the time, it was clearly induced by nivolumab. And so we did biopsy the patient, and it was an autoimmune type pattern. And I think what's interesting is that, my opinion is that I think it behaves more aggressively, kind of like what I believe you were implying. So in this case, it had an autoimmune type pattern. We initially tried just our standard use of prednisone, and there was no response. And it was interesting when we started to give more aggressive medications, initially solumedrol, and then finally we progressed to ATG, antithymocyte globulin, and that's when we were able to get we were able to get control. So that was one case where the immune response was really quite aggressive. In terms of in terms of what do we do routinely, again, I think the key thing is this patient we were notified very early, so we were able to admit the patient and do everything we needed to do. But I think just, as everyone has said, just awareness and early referral to the hepatologist to get a quick diagnosis is important.
And I have to remind you, these cases, they had healthy livers. So forget about, when you're talking about Dr. Finn, using these kind of medications in somebody HCC with cirrhosis, sounds very scary. If they are among the people who are going to have complications, I don't know how we are going to be able to manage them at all. So now that we're talking about cancer, I'm going to ask another question. The use of tamoxifen and how quickly it causes cirrhosis. That's what I saw, something like in 1 year, 6, 7 patients who actually in a matter of like 6, 7 months after they were diagnosed with breast cancer and they were treated with tamoxifen, they had, AST, ALT in the range of like 100. They told them, oh, go lose weight, you will feel better, whatever. And they came. They were already, 3 of them already had cirrhosis. 1 of them had F3 and no other risk factors. And they were not really fat, to tell you the truth. So what's your take on tamoxifen causing such a...
I don't associate tamoxifen with cirrhosis as being a high-risk event. Again, the risk-benefit, this drug has revolutionized hormone-positive breast cancer, as far as saving people's lives. So,
but that's the answer I get from oncologists. They want
to
keep the patient, the patient doesn't have breast cancer, but a year later, the patient, I had 5 cases, and there is this kind of like resistance to replace tamoxifen by something else.
I think also, I think these patients are also at risk for NRH. So in that situation, I may even biopsy them to figure out if it's really cirrhosis and and not NRH. Okay. Mm-hmm. So I actually haven't seen
another question.
Tamoxifen associated.
Yeah.
So, we've been using some of these chemo agents, on other diseases. So I have a number of patients who have had gastritis and colitis, presumably autoimmune, and I keep them on a PPI is very helpful, and the 5-ASA compounds are very helpful. Mm-hmm. And what I found is they cycle as they right after they get their treatment, their diseases get worse. So we keep them on a low dose of medication, and then 2 or 3 days before they get their chemo, we double or triple their treatment for a week, and that seems to help.
For the GI symptoms?
For the for the colitis and the gastritis.
Anybody else do that?
I've done that with steroids. I haven't done it with the 5-ASAs, but I don't see as much of the GI problems as I do the liver problems.
Yeah.
It's interesting with all of these drugs, we're all sort of learning about the side effects and management all at the same time, right? So it's like this, where we're all sharing our anecdotes and, hey, I did this and it worked, I did that and it didn't work, or this horrible thing happened, or whatever. And I think, as we use more and more of them, we'll get more and more data and we'll get more and more guidelines about what to do. I really like the ASCO guidelines on immune-mediated treatment. There's been some really good liver review articles about it. If anybody needs them, I'd be happy to share them. Just shoot me an email. But I think that it is a little bit of sort of playing with things a little bit and seeing what works for each patient. And I think the other thing to remember is that the data says, again, the earlier you start, the better the chance that you're going to have a resolution of their symptoms. But also, if the patient needs steroids or an immunomodulator, it doesn't affect the ability of the cancer to respond to the treatment. Okay? So if you've got an HCC patient that you have to give them prednisone, that's not going to prevent them from having a cancer response. So it's a balance, right? I mean, what's going to kill them? Is it the cancer, or are you able to control their hepatitis or their gastritis, which also can kill them if you can't control it?
Question.
Hi. I have a question about etiology. With the recent increasing incidence of NASH and NASH-related HCC, is there anything unique about these patients that would factor in your considerations in treating them with any of these systemic options first line, like thinking hypertension?
Yeah. So far, etiology has not been a very good predictor for certainly response to any of these drugs, and the common denominator just seems to be proliferation, inflammation in the liver, regardless of the cause. I mean, HBV is associated with certain genetic changes versus Hep C versus NASH, but it hasn't had any therapeutic implication or side effect implication yet.
Well, on behalf of my other co-chairman, Steve Hahn and John Donovan, I'd like to thank you all for attending and staying to the end.